Okay. So, hi everyone. Welcome to our today's session entitled The Cardio-Renal-Metabolic Condition in Diabetes with the collaboration of Boehringer Ingelheim. We are glad to have with us today Dr. Paola Atallah, President of the Lebanese Society of Endocrinology, Diabetes and Lipids. Welcome, Dr. Atallah.
Thank you, Mirna. Hi.
And we have with us also Dr. Mohamed Malek, President of the Lebanese Society of Cardiology. Welcome, Dr. Malek.
Thank you. Hello.
So, as we all know, 463 million people have diabetes in the world. The Middle East and the MENA region are one of the global diabetes hotspots. The number of patients in this part of the world is expected to increase by double by 2045. So, Dr. Atallah, my first question will be with you. What is the main cause of diabetes? Is it genetic, lifestyle, or by chance someone can get diabetes?
So when we want to talk about the cause of diabetes, we have to define which kind of diabetes, because mainly we have two big types of diabetes. Type 1, affecting usually children, it's autoimmune disease because our immune system is acting to destroying the beta cells of the pancreas. So they don't secrete insulin like they should do, and the patient doesn't have any more insulin, and the treatment is only by insulin injection.
Yes.
And the type 2 diabetes is more common. It's usually affecting adults. It's about 90 or 90% of type of diabetes. Usually patients are overweight or obese. Genetic factors here are very important with lifestyle factors.
Mm-hmm.
And usually when we talk type 2 diabetes, we know that there is a state of insulin resistance, which is very important in this type of diabetes.
Mm-hmm. So, doctor, what are the symptoms that someone should look for to seek medical help?
That sometimes diabetes is asymptomatic. So it's why in certain category of people, we have to go and screen for it. But when there is symptoms, it could be too much thirst, polydipsia, or too much urination, polyuria. It could be fatigue, it could be weight loss, it could be some paresthesia in the hands or in the feet. It could be some blurry vision. Many not very typical symptoms. The typical symptoms are polyuria, polydipsia, and weight loss.
And what is the normal level of blood sugar? And when a person is considered to have pre-diabetes?
Usually every time sugar is more than 100 or 1 gram by liter or 100 milligram by deciliter, we know it's not normal. We talk about diabetes when it's more than 126 milligram by deciliter, more than 2 times in the lab, not the test we do at home, the capillary level. And to complete the test and the diagnosis, we have to go and do in the lab the glycosylated hemoglobin, HbA1c. And when it's more than 6.5%, it's a diagnosis of diabetes. And in case we are dosing diabetes anytime during the day, even if the patient is eating, if it's more than 200 with clinical symptoms, also it's a clinical diagnosis for diabetes. Pre-diabetes is another stage, it's before diabetes. So level is more than 100, but it's still less than 126. So between 100 and 125, it's pre-diabetes. And if we do HbA1c, the glycosylated hemoglobin, it's between 5.7% and 6.4%. And if we do an oral challenge glucose test, like we do usually in pregnant women, we give the patient 75 grams of glucose and we test fasting, and 2 hours after. Fasting, it's more than 100, but less than 126. And 2 hours later, it's between 140 and 199. Like this, we can separate between pre-diabetes and diabetes.
So, Dr. Malek, we know that people with type 2 diabetes have a higher risk of developing heart diseases and kidney diseases. Why is it so? And can you tell us the link between these 3 diseases?
Okay. Thank you again. Hello. As we know, the major causes of death in diabetic patients is cardiovascular disease. It is very well known, and this is a global figure. Around 2 to 4 folds of increased risk of cardiovascular events, every diabetic patient will be in comparison to a non-diabetic patient. So cardiovascular disease is the leading cause of mortality worldwide. It is very well known figure. And this is also holds true, especially in diabetic type 2 patients, where 1 out of 2 patients with type 2 diabetes will die from cardiovascular event. This is also well known. Individuals with type 2 diabetes will have 2-fold increased risk of cardiovascular disease, including strokes, MI, and heart attacks, plus many other cardiovascular or vascular events. Up to 40% of patients with heart failure are living with type 2 diabetes. This is also a very well-known and common complication in diabetic patients, heart failure. It can occur early in the disease, not only in the later stages. And when this entity is associated with chronic kidney disease, we will have a worse prognosis. And definitely, this is known, one of the most common complications or reasons for hospitalizations in patients who are elderly or diabetic. Chronic kidney disease is associated with increased risk of premature death from cardiovascular causes. And we have a significant proportion of diabetic patients progressively developing clinically significant nephropathy. This is called the well-known diabetic nephropathy, which is one of the major causes for end-stage kidney disease, which is known as end-stage kidney failure or dialysis. This is one of the main reasons for dialysis, and it is with a percentage of more than 30% of diabetic patients will develop diabetic nephropathy within 10 to 20 years after the onset of diabetes. So these three together, when they are interlinked or when they are present in a diabetic patient, the muscles, the cardiovascular system, the heart muscle, the cardiovascular system, and the kidney, when they are together in the disease found in a diabetic patient, this constitutes the highest or the worst prognosis ever in a diabetic patient.
And Dr. Malek, do you think that every patient with type 2 diabetes is condemned to have these complications, the heart failure or heart diseases with kidney diseases, or can we avoid this?
Yeah, definitely prevention is a major element in, or it is the main point in our treatment protocol. But we know that diabetes in its complications, we have 2 types of complications: the microvascular complications and the macrovascular complication. It is very well known from studies that the microvascular complications, that's to say, when the small vessels are attacked by diabetes complications from inflammation, from endothelial dysfunction, from atherosclerosis, which are all consequences of diabetes. And usually microvascular complications, we mean by them the retinopathy, the neuropathy, the nephropathy. Usually these we can prevent or we can decrease progression of the disease early in the disease process when we treat glucose aggressively and when we control it. But this will not hold true, and we have less evidence when it comes to macrovascular complications, that's to say, the cardiovascular events and the definitely the MI and the heart attacks. This from evidence, we have fewer evidence that controlling glucose here, even aggressively, will not do the job as with microvascular complications. So we have another process to act on in diabetic patients, especially because diabetic patients usually have comorbid diseases like lipidemia, hypertension, and definitely these are the mainstay behind cardiovascular disease. Whenever we target hypertension, whenever we target lipidemia, whenever we target the renin, aldosterone, and angiotensin system by inhibiting it, we can benefit these patients in the disease process as far as kidney diseases, and in parallel with protecting the kidney, we can definitely reach a protection to the heart. Therefore, even in the early stages of the diseases, we can apply a hard treatment protocols concerning glucose, concerning all these systems I've mentioned before. And as a result of this, we can protect diabetic patients from becoming late in the cardiovascular disease process.
So, Dr. Atallah, can diabetes be reversed or completely cured if discovered at an early stage? And what are the preventions that we should follow to avoid getting diabetes, or for a person, for example, with a pre-diabetes, how can he avoid to have more complications at a later stage?
For sure. First of all, pre-diabetes, for sure, it could be reversed. When we do the diagnosis, lifestyle modification like diet, decreasing carbs and decreasing fat, losing weight, because most of the time patients are overweight or obese, and exercise. And studies have shown that diet and exercise could reverse the state of diabetes. And now we have guidelines that in some patients, and specifically those who are younger than 60, and women who did gestational diabetes should be also on drugs, not only on diet and exercise. And this state could be completely reversed. And also diabetes, if it's taken really in charge upon diagnosis with important lifestyle modification, strict diet, and if the patient loses weight, and if he start medication when we should start them aggressively. Also, many studies have shown that we can reverse diabetes, and the beta cells could become again very normal, secreting normal amount of insulin, and we can reverse the state also in insulin resistance. And also, I have to comment on the other point that not every patient, not every diabetic patient is condemned to have complication. Genetic factors are very important, and we don't know when we diagnose a diabetic patient if it's now that the diabetes started, because we know that people can stay many years undiagnosed. Even pre-diabetes can stay between 3 to 10 years before diabetes diagnosis, and patient could stay undiagnosed during many years. So treating aggressively when we diagnose the patient with the comorbidities, like Dr. Malek said, so treating lipids on diagnosis, treating blood pressure on diagnosis, screening for complication at diagnosis, specifically nephropathy. We have to assess the microalbuminuria to see if there is nephropathy, start blocking the angiotensin-aldosterone system, which can reverse this microalbuminuria, and patient could stay without complication in those cases. But genetic factors are very important, and we don't have to forget smoking, because smoking also is a factor, argyria is a factor to increase this the atherosclerosis, because all the complications are related to atherosclerosis.
So what are the latest guidelines in treatment, in diabetes treatment now, the latest?
Now since 10 years, we had many advances knowing the pathophysiology of diabetes. Before we thought it's only beta cells not secreting or beta cells secreting, but insulin not doing its job. So we were thinking about only insulin failure or insulin resistance. Now we know that the kidney is playing an important role in the retention of the sugar in the blood. We know that our gastrointestinal system also is playing a role in secreting incretins, who are very important in stimulating the secretion of insulin by the beta cells of the pancreas. It's why now when we want to treat a patient, for sure, every time we start with lifestyle modification and exercise, and depending on the state of the patient, we have every time to assess the cardiovascular state of the patient. If he presents already cardiovascular disease, or if he has many cardiovascular risk factors, if he presents with heart failure, if he presents problem of kidney, it's not, there is, patient thinks kidney they should have very high level of creatinine. No, it's not like this. Even little decrease in the capacity of the kidney, decrease of the GFR, this patient is high risk. So there is category of medication to prefer. And now we have two kind of category. We have the GLP-1 receptor agonists who are injectables. We prefer them for patients who already have atherosclerotic cardiovascular disease. I speak about myocardial infarction and stroke. Or patient, we have the pills working at the level of the kidney, SGLT2 receptor inhibitor, leading to increased secretion of sugar by the kidney. They will lead by the same time to decrease of the blood pressure. They will decrease the weight of the patient. They will decrease heart failure and risk of hospitalization for heart failure. They preserve the kidney also, and they have very good effect also of all cardiovascular event and cardiovascular death. So we have to discuss with the patient on those two beautiful drugs with proven efficacy with many trials to choose between those two drugs and to see if the patient have contraindication or not. He's willing to take them, because we know that when you prescribe a drug, compliance is the most important factor to have a good result when we are treating the patient. So now when we want to treat diabetes, it's not important to choose very powerful drug to decrease HbA1c. Our target is not decreasing level of glucose. Our target is maintaining a good level of HbA1c without weight gain. We want to decrease the weight without hypoglycemia, the sugar going low, with drugs protecting the heart and protecting the kidney. It's the target of the treatment. And there is other classification for other patients if their problem is the weight or the cost of or low blood sugar. We have other treatment to propose for the patients.
So Dr. Malek, to what extent a type 2 diabetes patient should be followed by an endocrinologist, a cardiologist, and a nephrologist? This is a very high burden for patients, you know, because each patient should be followed like every 4 months or 6 months with these 3 doctors. What is the solution for this? And we know that in many countries in the Arab world, patients are not used to go to a primary care physician. So this is a problem. They tend to go to the specialists.
Yes. I can say that if Dr. Atallah will agree with me that the primary care physicians can treat diabetes and follow up diabetic patients on a chronic basis when the patients are stable and for regular checkups. As far as a patient who is brand new patient, newly diagnosed, and or a patient who is diagnosed with diabetes and has resistant diabetes. I think these patients must be followed by an endocrinologist, because they are the best to give precautions, to learn, make the patient learn about his disease, and to avoid very high HbA1c more aggressively than a primary care physician, or even than a cardiologist or someone else. But as we know, diabetes is a multi-system organ disease. It involves the body from the brain down to the toe. So I think every specialty in medicine has to get involved in the treatment action of a diabetic patient, because with time, as we know, diabetes is not only a high blood sugar, but it is the comorbidities and the complications from this disease. And from this disease, we can have many complications, starting from strokes in the brain down to toe gangrene, amputations, cardiovascular events, nephropathies, neuropathies, retinopathies in the eye. So whenever a patient who is diabetic and has any complication out of his diabetes, even before reaching this level of complication, this patient has to be followed up meticulously, from the part of the blood pressure to the eye exam, to the neuro exam, to the kidney function, definitely to the heart and to the peripheral vessels. So every specialty has its role in treating this disease. From the primary care physician point of view, he should follow a stable patient, chronic patient, and he should give instructions and awareness. So in general, I can say that we are all in this front to confront a very morbid and chronic disease together. Primary physician, cardiologists, endocrinologists, and many other specialists have to get involved in against this disease.
Dr. Atallah, how do you usually coordinate between you and the cardiologist and the nephrologist when you have a patient with all these risk factors?
For sure, we have to assess the patient, and depending on the comorbidities and the risk factor, we can address the patient even to the cardiologist if we are thinking about a heart problem, or to the nephrologist in case we have a degradation in the creatinine, very high level of macroalbuminuria with resistant blood pressure. We cooperate all the time. We address the patient, sometimes to both doctors, because we know that we are talking about, we need a multidisciplinary approach, like Dr. Malek said. So many of our patients are seen at the same time by cardiologists, by nephrologists, and by us. But not all patients needs nephrologists. It depends on their kidney function.
Yes.
We address them when it's needed.
And Dr. Atallah, we know that
cardiologist.
Sorry, excuse me.
Most of them needs a cardiologist.
Yeah. So we know that children are being diagnosed more and more with type 2 diabetes because of obesity and the lifestyle changes. What are the guidelines for children, and are they the same as adults?
For children specifically, we are talking here about adolescent, because we are talking about type 2. It's not rare in a very little child. And usually we have to think about this when they are obese or overweight, specifically if there is a history in the family of diabetes, and if you have some signs on their skin, because many times we have symptoms of insulin resistance, like named acanthosis nigricans. They are black stria over the neck specifically, or the elbow or the hand. So here lifestyle and diet are very important, and even we can give drugs in adolescents. We have many drugs now we can give them. It could be reversed, but if not, if they stay in this state, they are not treated, when they grow up, they have risk also of cardiovascular and kidney disease for sure.
And Dr. Malek, do children have the same risks as adults of cardiovascular diseases if they are diagnosed with diabetes?
Children, no. We rarely see children with diabetes having heart disease. I can say we can have children with familial hyperlipidemia in comorbidities with diabetes and hypertension because of early stages of atherosclerosis having this problem. But diabetes per se in children is very rarely confounded with heart diseases. Allow me to add about the medications that Dr. Atallah have mentioned. If she can agree with me that metformin are still the first line of treatment, definitely without any compromise. And these are safe, inexpensive, and effective treatments. We as cardiologists, since 2008, the FDA has mandated a safety trial for every therapeutic treatment to be given for diabetic patients to be safe as far as the heart. And we were happy concerning this label from the FDA. Then, few years ago, around 4 or 5 years ago, we had a major breakthrough in medications, we as cardiologists in the field of diabetes, which are the GLP-1 receptor agonists and the SGLT2 inhibitors, because of the landmark trials that went years ago and has proven very effectiveness, very highly effective in protecting the heart from cardiovascular events and the kidney from going into end-stage renal failure. So we as cardiologists are very happy to have these drugs between us because of the very positive outcome trials that have occurred.
And Dr. Malek, we sometimes hear that some drugs or some medications cannot be taken for so long. For example, if you take it like for 5, 6, 7 years, you should change the medication. Is it true? And
this holds true for specific medications for the heart, which are like the nitrates, but I don't agree about this concerning the diabetic medications or the other cardiac medications, because most of these drugs have been studied for so many years over a long period of time and were definitely protective concerning the heart, the kidney, and the liver. These are the 3 organs which we are concerned about whenever a drug is given on a chronic basis. And if Dr. Atallah will agree with me, I'm not aware of any drug that is of tolerance concerning diabetic or cardiac medications other than the nitrates in our specialties.
Yeah.
If you want me to continue with the silent MI and the diabetes, this is very interesting field to go. As we all know, heart attack, most of the time we heard of in any person or a patient is oppressive chest pain, which is squeezing, which is burning, or even having fire in the chest, chest oppression. This is the usual chest pain that a patient who is having a heart attack will have. A special field called silent heart attacks. This can happen to anyone, but diabetic patients makes the most likely diagnosis of this entity, where up to 20% of diabetic patients will have a silent MI. What do we mean by silent heart attack? This silency can ranges from no symptoms at all, and the patient will have an attack, to mild, very mild symptom like feeling very mild chest burning pain or very odd aches in their chests. Even he might feel another symptoms other than chest pain, like nauseous, dizzy, cold sweats. He will feel less or more breathless. So these are very mild, non-specific symptoms where the patient having silent MI will have, and the diabetic patients are usually susceptible to these types of MIs because of many reasons.
Even if they, one question.
First of all, because the diabetics are at very high risk of cardiovascular disease, so they will be prone for having MIs and heart attacks. And the second reason behind silency is the autonomic neuropathy that will cause damage to the nerve endings, which are responsible to have pain in the chest. This will be damaged, and the patient with diabetes will have silent episode of heart attacks. How to avoid these events? Very important is to treat the comorbid conditions like quit smoking, treat hypertension, treat hyperlipidemia, control blood glucose level, exercise regularly, and definitely we should control our anxiety state and have low fat, low salt, and low saturated fat diet.
Dr. Atallah is again with us.
Sorry, regarding diabetes, there is misconception between the patients that with time drugs are not working. In fact, diabetes is a progressive disease, and with time we have to change the medication or to add medication. And sometimes if we change medication, it's because of problem in the kidney, and every time we modify our treatment depending on the kidney function.
Yes.
Because some treatment are not allowed if the kidney is not completely functioning normally. It's not the medication, it's the progression of the disease.
Yeah, okay, I understand. So, Dr. Atallah, we cannot but ask about the struggle of type 2 diabetes patients they are facing during this pandemic, I mean COVID-19. We know, we hear a lot that people with diabetes are more at risks of complications, and this created a panic between the diabetes patients, type 2 especially. So what are your recommendations for these patients during this pandemic?
Before getting infected by the COVID, it's very important for every diabetic patient to take all the precautions to
avoid catching.
To avoid the infections. So put his mask, wash his hand, the distancing, it's very important. Don't go when there is too many people, crowded places, and take his medication to have a good level of blood sugar, normal glycosylated hemoglobin. It's very important. But when he has the disease, we have many problems. We have facing many problems with the patient, because now with the treatment of the COVID patient who are hospitalized, usually the steroids are very important. They take cortisone, and with steroids we have a very high level of blood sugar, very difficult to maintain and to address. And now we have at least 5 or 6 patients with very difficult state of diabetes, and many also COVID patients are not diabetic, and when they are diagnosed with COVID, they start with very high level of blood sugar when they start the cortisone treatment.
Okay. So, and Dr. Malek, we know that COVID-19 have a very bad impact on the heart also. What do we know till now, and how can we protect our hearts even if we don't have heart diseases? The impact of COVID-19 is very high on the heart.
Definitely, it is very well known by now that patients who have cardiovascular disease, hypertension, diabetes, obesity, and aging populations are the highest among the patients who will get high morbidity and mortality rate compared to those who are non-diabetic, non-hypertensive, young adults who had COVID or coronavirus. It is very important for both populations to have the precautions that Dr. Atallah has mentioned, whether he is morbid or not, whether he is adult or elderly, he should take all the precautions concerning the mask, social distancing, and every precaution matters because of the surrounding of the adult non-morbid patient. If he has any elderly around him from his family, or if he has any patient with heart disease, with diabetes or hypertension. It was mentioned and reported statistically from many countries all over the world that most of the patients with the highest mortality rates are the elderly, followed by the patients who has cardiovascular disease, especially heart failure, followed by hypertension and or previous myocardial infarctions. These patients are among the highest mortality and highest morbidity rates who will be admitted to intensive care and will need respiration mechanically. These patients are of utmost importance to be isolated, to be kept in a safe environment with utmost care concerning their medications, drugs, follow-up, whether virtually or physically, whenever a simple symptoms has emerged in their body, they shall never except take it into consideration and see their primary physician.
Dr. Atallah, what is your recommendation for type 2 diabetes patients? Because we know that some patients, they neglect themselves when they go and they start with medications, for example. They wait like for 2-3 years to go back to their doctor. So what is the recommendation for patients to be able to maintain their sugar level throughout their life and to avoid having complications like cardiovascular diseases or kidney diseases?
Now, many studies have shown that treatment of type 2 diabetes should be aggressive since the start, very aggressive, because there is something we name the good legacy effect. When we treat our patient very aggressively, we know that later in life, they will have less complication. Mm-hmm. And the patient should know this. So we have to do more awareness. Either the primary care physician who will take care of the patient, if it's not the endocrinologist, and the patient and their family know that it's very important to take the medication, to do the diet, to do exercise, to quit smoking, to take all other medication regarding the comorbidities, medication for heart pressure, for blood pressure, for lipid also, because all of them are responsible of the complication. Because many patients start the medicine and they stop. They said, I'm doing exercise, I'm dieting. They don't want medication. They resist to take a pill, a simple pill they resist to it, because we know that aggressively treated, it could be reversed sometimes. And if it's aggressively treated, it will decrease the complication later on. Even if now we have very important drugs decreasing cardiovascular complication and kidney complication, we don't have to rely on this. We have to start to prevent those complications.
Okay.
You're back.
I'm back. So, doctors, I will be thanking you. Thank you for your very informative session. And hopefully science will continue to provide us with solutions for chronic diseases like diabetes and cardiovascular diseases. It was great having you with us. Would you like to add anything at the end of this session?
Yes, we have to stress on the fact that endocrinologists, cardiologists, nephrologists, as well as primary care physician are treating at the same time the same type 2 diabetic patient, assessing its cardiovascular risk and giving him the latest drug to prevent other complication, kidney or cardiac, and specifically heart failure. I think Dr. Malek also will tell you the same. Thank you.
Definitely, I agree with Dr. Atallah, and I, on my turn, thank you for this conversation. Yeah, it was a pleasure being with you, and thanks again.
Thank you very much. Bye, doctors.
Thank you.
Bye-bye.
Bye.
Bye.